Good afternoon, everyone. Welcome to CAQH Core's third town hall of 2023. I know our staff is excited to share with you some of our current initiatives, their progress, and where we are today during our webinar. Before we go ahead and get started, though, I'm going to run through some logistics on the next slide. If you'd like to access today's webinar materials, you can do so by downloading the presentation slides from the handout section of GoToWebinar. That's on the right-hand side of your screen. We'll also send out an email in the next 1 to 2 business days with information on how to access those slides, as well as a recording of today's presentation. If you have a question for any of our speakers at any time throughout the webinar, you can go ahead and submit it in the questions panel on your GoToWebinar menu, and we'll have a few minutes at the end to take a look at those questions and answer them for you. Looking at the next slide, before we go through our agenda, we do just want to let everyone know that we are having a CAQH Connect conference this month. It's September 27th to the 29th in Washington, D.C. So if you haven't done so already and you're interested in joining us, please feel free to register. If you have a minute right now on your phone, you could take a picture of that QR code to get to the registration website. The link will also be available when we send out the slides to click and just go straight to that page and sign up. Okay, looking at our agenda, today, like I said, our core staff is excited to share some updates with you all. We're going to start with a brief CAQH core overview, then we'll provide an update on federal regulatory activity. We'll also touch base on some of our issue briefs that were released this summer, and we'll follow that up with our operating rule development progress for this year. We'll wrap things up with a Q&A and a call to action, and that'll be it for today. So with that, I'm going to go ahead and pass things over to Erin Weber.
Thanks, Jackie, and thanks so much to everyone for joining us today. I'm Erin Weber. I'm the Vice President of the Committee on Operating Rules for Information Exchange, otherwise known as CORE. Also speaking today, we have my colleagues, Caitlin Powers, Mike Phillips, and Tanner Fuchs, who are all going to share some updates around the rule development efforts that we have underway here at CORE. And then my colleague Bob Bowman is on the line as well for questions at the end of the session. So thanks everyone for joining us today. A hot tip, do not schedule a webinar the day half your team is traveling in for a meeting. We had to do a lot of substitutions today for speakers, so appreciate your patience with us. Today we are going to talk about, first, I'm going to give you a quick overview of CORE and our background. The mission and vision of CORE are really to drive the creation and adoption of operating rules. And operating rules are business rules that support standards. They can't conflict or duplicate the content of a standard, but they really build on standards to accelerate interoperability and align data exchange between both business and technical perspectives. We see ourselves as an industry-wide facilitator, and not only in our role to bring the industry together to develop and approve operating rules, but also to measure the impact of those operating rules and offer certification on those operating rules and provide education to the industry on issues related to standards and interoperability, like these education sessions that we do. A little bit more background on operating rules, and we can go ahead and go to the next slide. For those of you who might not know the background of CORE, CORE was founded back in, I believe it was the early 2000s, shortly after HIPAA was passed. HIPAA required the adoption of electronic standards for administrative transactions in healthcare, so eligibility, claims, payment, and remittance advice. The challenge was, as the industry began to implement these standards, there was still a disconnect in the ability for particularly providers to automate data exchange across multiple health plans, because there were inconsistencies and a lack of communications in how that information should best be exchanged. So providers in particular, if you think about eligibility transactions, were getting different bits and pieces of information back on a transaction depending on the health plan that they were working with. And there were no rules of the road for infrastructure around how and when to exchange these transactions as well. So it made it very difficult for providers to automate their systems. So the industry came together and created CAQH Core, modeled after the financial services industry, where they have developed operating rules for their ACH network, for electronic funds transfer, as well as the ATM network, so that financial institutions can seamlessly exchange information. And that was the vision for healthcare as well. And we've certainly made some progress in that space since the early 2000s. In 2010, CORE was designated as the, maybe it was 2011, as the National Operating Rule Authoring Entity for all of the HIPAA mandated administrative transactions. So for every HIPAA mandated standard, operating rules are required as well. So some have been adopted, some of our rules are voluntary, and we continue to update and develop those rules over time. On the next slide, I keep saying we, and who I'm really talking about are our core participating organizations. We have more than 100 organizations who come together to develop operating rules, chair our work groups and subgroups, and really help drive the direction of the work that we do. If your organization is not on this list, we encourage you to reach out to us to learn more about how you can get involved and directly contribute to the development of operating rules. On the next slide, I want to highlight that the operating rules really span the entire healthcare revenue cycle, from the time a patient's visit is scheduled all the way through payment. We have eligibility and benefit operating rules, claim status, and payment and remittance operating rules that have all been federally mandated under HIPAA, as well as operating rules for prior auth and claims and benefit enrollment and premium payment transactions that are available for voluntary implementation. In addition, I mentioned before, we do also have a certification program at CORE, and that is because we really believe in driving adoption and measuring adoption of the operating rules. So CORE certification helps organizations understand and confirm that their systems are in compliance with the operating rules. It helps demonstrate your commitment to interoperability and administrative simplification. Both providers, health plans, vendors, and clearinghouses can all become CORE certified. And to date, we have awarded 410 certifications. We also have a recertification program every 3 years to make sure that organizations continue to be aligned with the most updated operating rule requirements and continue to maintain conformance as systems are evolving. On the next slide, you can see the list of all of our CORE certified health plans and vendor products. I can highlight in 2023, we've had new certifications for a number of organizations, including Nant Health, View, Palmetto GBA, Healthcare Fiscal Management, Inc., and P-Verify. And we've recently awarded a number of recertifications as well for Cigna, MVP Healthcare, Prime West Health, the State of Alaska, North Dakota Medicaid, and Nant Health. So congratulations to all of those organizations on their certifications and recertifications. So on the next slide, I'm going to talk now about some updates. We've been keeping you all updated over the course of the last year in our role as the National Operating Rule Authoring Entity. There is a process that we follow to submit potential new or updated operating rules for federal mandate under HIPAA. And if we go to the next slide, we've really outlined here the steps that we take anytime we submit rules for consideration for federal mandate. And this timeline here really aligns with the work that we've done over the past year plus to bring rules forward for consideration. So CORE has a separate board of directors that is equal parts providers, health plans, and vendors. that determine when a set of rules is ready for consideration for federal mandate. So the board will vote and draft a letter that goes to the National Committee on Vital and Health Statistics, or NCVHS, which is a federal advisory committee to HHS. NCVHS is responsible for not only HIPAA administrative simplification provisions, but privacy and security provisions of HIPAA, as well as population health issues, among other issues in healthcare technology. So they are composed of academics and industry experts who really spend a lot of time reviewing proposals and drafting recommendations to the Secretary at HHS. Once NCVHS receives a letter from CAQH Core on operating rules, that triggers a process whereby the Subcommittee on Standards will publish a request for comment to get industry feedback on the value of the proposed operating rules and get a sense of what the lift would be to implement them and what the value and ROI of the rules will be. They also held an industry hearing at the beginning of this year where they invited industry stakeholders, a wide variety of industry stakeholders, to share their perspectives and have a discussion with the committee members. So once NCVHS gets all the feedback they feel like is sufficient from the industry to make a recommendation, they will then send a letter to the Secretary of HHS making a recommendation on whether or not to adopt the proposed operating rules. In this case, on June 30th of this summer, NCVHS sent a letter to the Secretary recommending most of the proposed operating rules for adoption under HIPAA that the Corps had presented, except those 4 attachments, and we'll talk about that in a minute. Once that recommendation goes to CMS, HHS or CMS has 90 days to issue an interim final rule to the industry with a public comment period, usually a 60-day comment period. They will review the public comments, and then depending on whether there are significant feedback, they then adopt the rule as final, which essentially mandates the operating rules. Once the operating rules are mandated, industry is given 25 months to implement and adopt the new rules. So as I walk through some of these recommendations and the operating rule requirements within, remember that there is still a public comment period to come, and that after that is all finalized, there will still be an additional 25 months to plan and implement the operating rules, assuming things move forward. So on slide 14, we highlight the key recommendations in the letter NCVHS sent the Secretary this summer. So in the letter, NCVHS recommended that HHS adopt updated infrastructure rules for the eligibility and benefit, claim status, and payment and remittance advice transactions, that they adopt an updated core connectivity rule, and they adopt an updated version of the eligibility and benefits data content rule. A little bit of history here. These rules, there are prior versions of all of these rules that were adopted in the 2012-2014 timeframe. And obviously, we all know that healthcare technology has changed significantly in this time period. So these rules have been updated to reflect that, and I'll talk about that in more detail in a minute. They also recommended adoption of a new operating rule, which is called the Single Patient Attribution Data Content Rule, which requires plans to send back information about whether or not a specific patient is attributed to a provider in the eligibility and benefits transaction in a value-based payment program. They did not recommend, the board had recommended the adoption of the new core attachment operating rules for claims and prior authorization. At this time, NCVHS elected not to recommend those rules because there's not yet an attachment standard adopted under HIPAA. And those that are following the policy and rulemaking process closely will know that CMS did put out a proposed rule for an attachment standard at the end of last year. But that has not yet been finalized. So we'll continue to follow the industry conversation and industry progress around a standard for attachments, and then reevaluate these rules once that standard is finalized. The other thing that they didn't recommend in their letter, and this is consistent with every operating rule that has been federally mandated to date, is to say that the core certification requirement language in the operating rules doesn't apply to federal rulemaking. So essentially that means core certification is not required, but we include that information, the core participants include that information in the operating rules because we do have the certification program. Since we're kind of talking about NCVHS and the recommendations they made this summer, the other thing I want to highlight is along a similar time frame as the operating rule recommendations followed, X12 put forth a recommendation to adopt updated versions of the claims and remittance advice standards. Their NCVHS hearing was the day prior to the hearing on operating rules, and the comment periods were the same. NCVHS did not recommend adopting updated versions of those standards for a variety of reasons, and that letter is up on the NCVHS website as well if you're looking for more information and background there. So I'm going to take a drink of water, and then I'm going to talk about some of the contents of these recommended operating rules and what it'll mean to the industry as they become implemented across all HIPAA covered entities. So let's talk about the infrastructure updates first. So in addition to modernizing connectivity requirements, which I'll touch on next, the infrastructure updates align the template for the Master Companion Guide with non-5010 versions of the X12 standard. This promotes flexibility as NCVHS and HHS consider updates to standards, and CMS references newer versions of standards in proposed rulemaking. We're thinking about the proposed attachment standard for the 6020 version of the 278 for prior auth and the attachments. Additionally, the system availability requirements are updated from 86% to 90% per calendar week for systems conducting the eligibility and benefits and claim status transactions. This really helps to ensure platform availability during off hours and weekends. So it's interesting because 4% increase doesn't sound like a lot, but the result is actually 364 hours of system uptime annually, or an hour a day, without sacrificing a health plan's ability to accommodate larger system improvements or maintenance, because there's a new quarterly system availability requirement as well. I mean, couldn't we all use an extra hour a day? In practice, universal adoption of these infrastructure requirements for system availability and connectivity really will create a new floor for industry expectations around these transactions. On the next slide, let's talk connectivity a bit. And when we did a webinar, we shared a bit more detail on these operating rules a few weeks ago. So if you're interested in getting more detail, I'd go back to our website, listen to this webinar. And over the next few months, we'll be putting out more detailed content as well. But all of the rules are also available for free on our website. But thinking about connectivity. As a reminder, the phase 1 and 2 core connectivity rules, or version 1 and 2 now, are currently federally mandated, but many of their requirements are not in alignment with today's best practices. And that's because, again, these rules were developed almost more than 10 years ago. Organizations continue to maintain these outdated protocols simply for compliance reasons. So our connectivity subgroup specifically sought to connect and align our work with the ONC FAST Task Force, in particular to support the multiple standards anticipated to be proposed for attachments. While I won't read every item included on this slide, I want to direct you to several key improvements. The first is updated security standards referencing OAuth 2.0 and digital certification, which represent modern best practices for the exchange of information and reduce reliance on outdated technical methods like username and password authentication. Several updates, such as those made to error codes and new references to the X12 version 6020, really ensures alignment with current technologies and business scenarios. And then lastly, and perhaps most importantly, version 4 adds support for REST exchange protocols, empowering the use of APIs for the exchange of health information in alignment with national objectives. So the tangible benefits of this connectivity update include the expansion of available trading partners, security updates, and maintenance of the safe harbor requirements that are well accepted by industry and contribute to a high-value implementation. Under the currently mandated versions of connectivity, health plans and vendors are required to maintain SOAP and MIME methods, plus accommodate mutually agreeable connections. This update eliminates MIME, which has become outdated, and as mentioned, require support for REST protocols. These changes really empower provider choice of how information is exchanged, allowing them to specifically request the exchange information using EDI or through API formats, while maintaining the ability to exchange using other secure, mutually agreeable methods such as SFTP using the safe harbor provision. That's it for connectivity. Again, if you have any questions about these rules, you can always reach out to our team as well. I want to highlight some of the really exciting and I think maybe most impactful updates that are included in the updated and new eligibility and benefit data content rules. So these updates really represent top priority items identified across core participating organizations, including the growing complexity of benefit design, the need to automate prior auth requirements, and the use of telehealth driven by the pandemic. So specifically, the updates add new discretionary and mandatory service type codes, including dental, for a new total of 178 STCs, which means that providers will receive a wealth of additional coverage detail and patient financial information in real time, like copay, deductible, coinsurance, for these services in the eligibility response. They require specific coding to indicate if telehealth is covered. They require the return of maximum and remaining benefit data critical for services like PT and OT when you only have 2 out of 10 visits left. They require return of eligibility and benefit information at the procedure code level for PT, OT, surgery, and imaging. They support the inclusion of detailed information for tiered benefit coverage, and they require plans to indicate if prior authorization is required at the STC and procedure code levels. So we all know, in particular, commercial health plan benefit design has become more complex, and among other changes, requirements for prior authorizations are more common at the very specific patient, provider, and procedure levels. This update will have significant impacts for healthcare operations because it will empower providers and patients to receive greater detail about their benefits and prior authorization requirements before or at the point of care. It's also complementary to the recently proposed lookup tools that are included in the electronic prior auth regulation, another regulation that came out at the end of last year, which may not be patient and provider specific. So the rule updates also align with the other current regulatory priorities, such as the No Surprises Act, because it automates the return of very granular coverage details. So this will allow providers to determine if a service is not covered, and as required under the NSA, issue a good faith estimate for self-pay care, addressing a currently unmet business need related to NSA implementation. And then finally, by leveraging the eligibility and benefit transaction, CORE has also addressed the growth and adoption of value-based payment models in the single patient attribution rule, which provides detail on a patient's attribution status in real time. So quick recap. We have new, I think it's what, 5 updated rules and 1 new rule that have been recommended by NCVHS to HHS for federal adoption. So if you go to slide 18, the next step in the process is this expedited interim final rulemaking process. So we will keep you all updated as we hear and a potential IFR is released. We'll also be launching a dedicated website for all of the NCBHS recommended rules in the process to keep industry up to date and informed. So, any questions about this, put it in the chat or reach out to us after. We're happy to help. I'm going to shift gears a little bit now, highlight a couple issue briefs that CAQH released this year that might be of interest to you, and then really turn it over to the team to talk about some of our rule development efforts that the core participants are leading this year. So in 2023, CAQH issued 2 new issue briefs that are related to supplemental questions that are included in the CAQH index. So most of you are probably aware of the CAQH index. It tracks industry adoption of standards and collects data from across the industry. And we always ask some additional questions on hot topics that are of interest to industry. And so this year we asked about to really understand how plans and providers interact with delegated management vendors who are kind of delegated by these organizations to improve how information is exchanged. We asked providers about the number of vendors that they interact with for medical services, the types of services that were delegated, and the methods vendors used to request information from providers. Although less than a quarter of plans and providers were interacting with DMVs for medical services, they found that the process is highly manual and not standardized. And so there's a definite opportunity here to reduce administrative burden. The second topic that the index asked about was in particular to medical and dental providers about the number of good faith estimates as part of the No Surprises Act, which I mentioned before, about the number of good faith estimates they're generating and sending, as well as methods, time, and costs associated with performing these tasks. And providers were also asked if they had started assuming the role of a convening provider. So I think what the research found is that the industry really needs to focus on helping to ease the transmission of this data, because right now it is a primarily manual process. So there are efforts underway to develop technical infrastructure and industry-wide standards for exchanging this information, and it is much needed. So I encourage you to take a look at those. And now I'm going to turn it over to the team to talk about 2023 operating rule development on slide 22. If you are a core participant, you know that we have kept you all very busy this year. We have 5 rule development and maintenance efforts underway or planned for this year. We are deep in the development of healthcare claim operating rules, particularly around data content, as well as value-based payment data content operating rules, which our team will share with you. We continue to maintain the core code combinations for those adjustment and denial codes in the remittance advice transaction. We just launched an update to the EFT and ERA enrollment data operating rules, and we are very shortly launching a joint work with NCPDP, the Pharmacy Standard and Operating Rule entity, to identify how best to share eligibility information on medication eligibility using the 270-271 transaction. So with that, I will turn it over to Tanner from our team to talk about the claims rule development.
Great. Thank you very much, Erin. So starting in mid-2022, CORE launched an environmental scan to better understand the impact of non-uniform data on first pass denial rates. Now, CORE conducted interviews including providers, health plans, vendors, government agencies, and standards development organizations, really encompassing a broad range of industry stakeholders when talking about these issues. And what these interviews and accompanying research told us was that often the data being shared between providers and health plans vary significantly, leading to increases in manual intervention within the claims submission process. Our research showed that this is certainly a problem that is not going away anytime soon, with reports indicating that initial denial rates are actually only rising, which further highlights the need for uniformity and consistency of the data shared. So with the formation of the healthcare claims subgroup in early 2023, the vision for the work to be done was very clear. Establishing data content requirements through operating rule development for transactions supporting claim submission is the key to a more streamlined claims workflow, as uniformity of data upfront can actually help to avoid those initial rejections, as well as potential costly downstream denials and appeals. So with that vision in mind, and moving into the next slide, you'll see the topics that the subgroup participants identified as focus areas for healthcare claim subgroup rule development. And I briefly want to highlight the significance of the work and potential impacts to industry that operating rules can provide, starting with telehealth POS plus modifier placement. So defining place of service and modifier combinations provides both standardization and uniformity when providers bill for remote care scenarios. Telehealth billing requirements are often very nuanced and variable to several different factors, two of which being place of service codes and modifier codes. So the subgroup work seeks to bring uniformity to communicating the different types of telehealth care situations. Now, we focused on POS codes 10 and 2 and modifiers 93, 95, and GT because participants shared that while these are some of the most common, an operating rule would make their use more predictable amongst stakeholders, taking out a lot of the guesswork we heard providers previously had to do when deciding when and how to use these POS codes and modifiers. The next focus area looks at an associated claim submission transaction, that being the 277CA. So for those of you on the line who may not know or are not as familiar with this transaction, the 277CA is a companion transaction to the 837 claim that will return an unsolicited response back to the claim submitter regarding any rejection reasons the claim may have experienced before entering a health plan's adjudication system. So with that in mind, the subgroup participants worked within the scope of the 277CA to understand how to leverage the data returned on the transaction to better support clean claim submissions. And what's really important here is that having clear, concise error reporting data returned that is actionable will allow for providers to quickly identify issues with their claims and get resubmissions out the door faster. So with the increased standardization that operating rules bring, the 277CA really proves to be an effective tool in supporting clean claim submissions. And lastly, the subgroup spent time discussing potential requirements to help support successful and timely submission of COB claims, or in this case, claims that go to a secondary payer or secondary plan after the primary health plan has paid. And CORE found that often COB claim requirements are difficult to find and vary from payer to payer. So standardizing both the minimum set of data elements to ensure successful submission of COB claims, as well as where and how to find this information was of high importance during subgroup discussions. And operating rule requirements outlining a minimum set of data elements to be included on COB claims sets a standard and predictable floor of data needed for a health plan to process COB claims successfully. Having this information electronically accessible and standard in format will make it easier to track these data requirements down, as well as other plan-specific COB billing guidelines. So this work is continuing right now as draft rule requirements are being written in preparation for our last subgroup meeting, which is actually taking place later this month. And that will give subgroup participants a chance to review and provide feedback on draft rule language before it moves into our review work group stage. So all this work is actually being done in tandem with the work of the other subgroups as well. So with that, I will actually pass things over to Mike Phillips to discuss the work or the value-based payment work that CORE is doing.
Great, thank you, Tanner, for that excellent overview. So I'm going to cover the value-based payment operating rule development for you. First, beginning with some of our business challenges, and forgive me if you've heard this refrain before, but the business challenges largely align with what we encountered in a fee-for-service environment. That if we address in value-based payments can really drive that automation and interoperability in this space. So we identified, and again, just to reiterate this idea of we as CORE and its participating organizations, we identified inconsistent data, and maybe even more so than a fee-for-service environment. Data sharing is integral to success in value-based payments. However, data standards are often variable, and as value-based payment models adapt to address things like health inequity, data sets that address social determinants of health are often incompatible, which can hinder value-based program design and the exchange and administration.
Hey, I think this is Erin. I think we might have lost Mike's sound. He is another one of our team members who is in transit today. Hey, Mike.
Other items include limited results. Now, savings. In large part, value-based payments are really an eye on costs the last decade. Hello?
Oh, Mike, you just cut out for maybe the last like minute.
And then, amazing, excellent. Always good to know that things are working perfectly. So anyways, I'm sorry about that, folks. So the three main business challenges I'll summarize are inconsistent data. Really, there's multiple data sets and multiple vocabulary standards that limit data sharing in VBP. There's limited program results. VBP has really looked at an opportunity to drive up quality and drive down costs. And over the last decade or so, many models have failed to realize that opportunity. And then lastly, an emerging area is, as we have limited or variable results overall, we've seen a rise in program complexity. So program stewards such as Medicare and other stakeholders are looking to gain that increase in quality or gain that drive down in costs or program savings. And due to that, they make benchmarking more restrictive, or they add in different methodologies that can address different aspects of the patient experience, such as addressing health inequity. So in order to address some of these items, the vision of the core rule development group for value-based payments was to leverage the HIPAA-mandated benefit enrollment, as well as the non-HIPAA mandated attributed patient roster, plan member reporting rule, which core facilitates through the attributed patient roster operating rule, as well as the claims transactions to facilitate uniform exchange of information, including sociodemographic information, as well as strengthening interoperability and value-based payments around terminology and infrastructure requirements. This was really carried out over the course of 2022 and into now in 2023, where the subgroup for rule development has just concluded, and the membership of that is reviewing the draft rule requirements to pass on to a review work group and eventual approval by the core participating organizations and board. So next slide, I'll go over some of the accomplishments and some of the significance of this in greater detail, excuse me. So three main categories here. First, as I alluded to previously, the core group strengthened the exchange of sociodemographic data and achieved this in three main ways. One is a new draft benefit enrollment and maintenance data content rule, and then two updated rules. One is updates to the benefit enrollment and maintenance infrastructure rule, and then updates to the data content and infrastructure rules for our attributed patient roster, which helps facilitate the plan member reporting transaction, another flavor, if you will, of the X12 834. This is really significant because it adds impactful sociodemographic data inclusions to HIPAA mandated and voluntary transactions, helping standardize upstream exchange. So bringing in sociodemographic data at the point of member enrollment to ensure that programs are designed inclusive of these sort of standard insights and reflective of the population that the payer is serving or health plan is serving. By extending some of these requirements to the attributed patient roster rules, we're helping to enhance plan to provider data exchange in that the sociodemographic data collected at the point of enrollment can now be used as a standard pipeline to providers participating in value-based contracts. And it just ensures that infrastructure rules are inclusive of value-based payment requirements, something that we will continue to expand upon in the future. The real significance gets carried through here because it makes sociodemographic data in value-based payment usable. And it also addresses CMMI evaluations that data availability and quality slows health equity progress. The more that value-based payment models are identified in their ability to address health inequities, the more that high quality standard data becomes important. The second point here in empowering engagement with value-based payment methodologies, this was achieved through new draft data content requirements for the healthcare claim submission. Healthcare claim submission data content rules. This was worked on collaboratively with the healthcare claims subgroup that Tanner just detailed. And this was really focused on aligning industry requirements for additional claim submissions and structuring this transaction to help providers include the information that support value-based methodologies such as risk adjustment. And this really functions as a component of a suite of operating rule requirements that reduce burden. Overall, the significance of value-based payment are this enhances the reporting of non-medical factors, which are increasingly being used for quality and risk adjustment. I'm talking not only sort of chronic conditions, but also the presence of social determinants of health, often recorded through ICD-10 codes. It also encourages greater provider engagement in the administration of value-based payment models by easing reporting of these valuable diagnosis codes that feed into quality measurement and risk adjustment. And lastly, tying this all together is that the subgroup worked on a framework for semantic interoperability in value-based payment. Now, while this is not a operating rule in the traditional sense, it is a glossary of sorts that can be used as a resource within the operating rules and externally to the industry. And it's really getting at the idea that there's a million different ways to define the value-based payment methodologies that we all encounter in our day-to-day operations. And this is a resource that is looked at as somewhat centralizing to many of the disparate sources out there, where it can act as somewhat of a single source of truth, at least for our operating rules and hopefully across our industry stakeholders as well. This glossary, once again, will be referenced directly in the operating rules, the draft operating rules, and will serve as a basis for some of CORE's value-based payment work going into the future. So overall here, the CORE value-based payment group assisted with the drafting of 5 new or updated operating rules, as well as 1 core and industry resource that ultimately is going to help drive automation and adoption of value-based payment models. These are incremental steps, of course. You can't eat an elephant in one bite, but we really think that this is of high value, particularly standardizing data intake at the point of member enrollment to help inform the design of value-based payment programs and help target populations that may be experiencing health inequities. So I'm going to pause there. Thank you all for your attention, and I'm going to pass it on to my colleague, Caitlin Powers. So Caitlin, take it away.
Perfect. Thank you so much, Mike. And our third area for role development for 2023 is the EFT and ERA enrollment data roles. While these roles recognize the need for ongoing maintenance and establishes a policy to review them no less than annually, industry stakeholders requested a more substantive adjustment this year to improve the ability to detect fraud and support streamlined workflows. Additionally, there's an ongoing need to drive greater adoption of the EFT and ERA standards. To address these business needs, CORE is exploring updating the operating roles to simplify provider enrollment through consistent data requirements and electronic enrollment methods. Earlier this year, CORE conducted interviews to evaluate current and emerging needs and launched the EFT and ERA enrollment task group last month to evaluate 5 opportunity areas for role updates. We can see those on the next slide. So these are the 5 opportunity areas. The first is to enhance the data sets by revising and improving data elements and their groupings. The second area is to provide more flexibility in the arrangement and location of the data sets. Third, the task group is considering opportunities to strengthen fraud detection capabilities. And fourth, the fourth opportunity area is considering ways to facilitate efficient bulk enrollment. And lastly, the task group is exploring requirements for notifying providers of enrollment, disenrollment, and any updates made to their EFT and ERA. You can go to the next slide. Perfect. And the last thing I wanted to bring up today is our upcoming Joint Eligibility Role Development Initiative with the National Council for Prescription Drug Programs. CORE will be launching a task group to consider operating role requirements to support the exchange of coverage and benefit information for medication covered under the medical benefit. Please be on the lookout for that call for participation in the coming months, and I hope that you'll join us. I'll now hand it over to Jackie for a Q&A discussion.
Thanks, Caitlin. If we take a look at this slide, just a reminder, if you do have questions based on what you listened to today, please feel free to submit it in the right-hand side of your screen under that question section on your GoToWebinar menu. We did receive a couple of questions throughout the presentation, so thank you for submitting. I'm going to go ahead and ask the first one. The first question is, will the expected prior auth regulations impact the eligibility operating rules at all? I'll pass that either to Aaron or Bob. But
that's a good question. I had to find the mute button. So I think it's fair to say that the upcoming prior auth regulations, at least what we saw in the original proposed rule, will really be complementary to what is included in the eligibility rules. So those rules are really around sharing prior auth information, querying whether or not a prior auth is needed, whereas the eligibility transaction has the ability to give, procedure, provider, patient level information on whether a prior auth is required, and then continue through the actual prior authorization process. That would be separate from the eligibility transaction. So it's really a use case driven approach to align with the industry and the market. But we'll be sure to, we'll be taking a look at it and adding our comments and looking to you all for your thoughts as well when the next version comes out.
Great, thanks, Erin. And taking a look at our next question, why aren't all of the STC codes included in the eligibility rule update?
Hey, this is Bob, and I can take this one. Feel free to weigh in, anybody else. I think one thing that's important that all Tanner, Mike, Aaron, and Caitlin have all mentioned about the rule development is that we do this through a consensus-based approach. So we have not included all of the STC codes because our participants really worked through the ones that were really priority for this next round of operating rule development. And so that consensus approach allowed us to add from that original 50 or something to now well over 150. So we've added over 100 more STC codes to this latest rule to get the industry to take that next step forward in presenting this information back to the provider when they inquire on those specific benefits that the member may have for those specialties. So those specialty providers now have better access to data about those specific benefits that they're most interested in. There's well over 200 STC codes, I believe, in the version 5010 TR3 for the 270, 271 transactions. So we haven't taken all of them, but this gives the industry that approach that they can take to remediate the systems, build those databases, allow vendors that conduct these transactions in between the provider and the health plans to fix their software, update them, to provide this additional information to support those STCs. Because we know future versions of the X12 standard allow for and require the support of any STC code. So this is a great bridge to go from the 5010 to the next version by expanding that list of STC codes through operating rules.
Awesome, thanks, Bob. We did just have a question come through asking if the 999 reports will be mandated anytime soon. I'm not sure if we have any insight on that.
Yeah, that's another great question.
Yeah, go ahead, Bob.
Go ahead, excuse me.
It's a hard question. Yeah. I think the answer is we don't know, but NCVHS has recommended, I think multiple times to CMS to consider requiring the use of the 999. Bob?
Sorry, I was coughing there. I agree. NCVHS has recommended them a number of times. We're waiting for HHS to make recommendations and potential regulations around the use of the standards for acknowledgements. However, the core operating rules do require the acknowledgement. So any of those core certified entities that you might see on our website, those health plans, vendors, and clearinghouses, all have confirmed through certification that they do conduct the appropriate acknowledgements. So it's always a good vehicle to check out our website, see who is certified, ensure that your vendor is using the right acknowledgements to make sure that you get the information that you need, and understanding that when a transaction may or may not have made it through for adjudication, for example, for a claim, or if a batch of prior authorizations that you sent in for a group of patients may have failed at the front end of that adjudication system. Those 999s are really helpful and really key for a constructive conversation between systems as they conduct the transactions.
Great, thanks Erin, thanks Bob. We had another question come through mentioning the question earlier that regarded the prior authorization rule. The question referenced the 270 and 271 rule impacts. Given that CAQH Core has prior auth rules, what is the plan for those rules?
This is Erin. That's a good question. So our process is anytime a new standard is introduced or standards are updated or really any sort of regulatory activity occurs that is related to our operating rules is to do a thorough review of that. And we will engage our participating organizations to help us determine, do we need to revisit the operating rules? Are there updates needed? And so until we see what that final rule is, it's hard to say, but we will certainly do that evaluation when the time comes.
And maybe just to add on real quick, a really important point here that perhaps isn't voiced often enough is that the 278 prior authorization transaction is federally mandated. If providers wish to conduct that transaction, then health plans have to use it to confirm, or it is a HIPAA mandated transaction. So if you're not receiving the appropriate types of feedback from your health plans in conducting the 278, then that could potentially be a HIPAA violation, right? So the use of the transactions are required under HIPAA. The operating rules that we've developed for the 278 as well as the 271, both for data content as well as infrastructure for the 278, really can help the industry implement the transactions in a more uniform and consistent way across the 4 stakeholder types that we identify. So again, the transactions can be really helpful. The operating rules help implement the transactions, and the business use cases that we all kind of lay as a foundation for both the standards and the operating rules are really what's going to be key in moving the industry forward, and which approaches can be most helpful for those types of providers or the way that they've set up their workflows, right? One workflow may be best for a provider in the office, right, when the member is there. Another workflow potentially for the 278 might be to batch those up and send those in for that specialist who has a host series of transactions or the host series of visits they'd like to plan and plot out for the next month, right? So the use case driven approach can be really helpful in helping determine what's the best approach for both the transactions and the operating rules that align with them.
Great. Thank you, Bob. Thank you, Erin. And thank you, everyone who submitted your questions. With that, we're going to go ahead and take a look at the next slide and wrap things up. I'm going to pass things back over to Erin with a brief call to action and an update on our upcoming education events.
Great, thanks, Jackie. Hopefully you all found today's session to be useful. We would encourage you to consider becoming a core participant if you are not already. Our work is really a result of the input from the core participants and the direction that you all give us. So the more the merrier, and the more comprehensive rules that we can develop. If you are a vendor or a plan, consider becoming core certified to really demonstrate your conformance to the operating rules. And most importantly, whether or not you're core certified or a participant, become an advocate. This is an important area of work, and it impacts all of us. And so we encourage you to get involved in the regulatory process, have your voice heard, and work with us or others to measure the impact of standards and operating rules on your own efficiency metrics to help inform industry and help policymakers make better, more informed decisions about how to move forward. On the next slide, just a couple upcoming events, actually a lot of upcoming events. We have a lot of webinars coming up before the end of the year. I can't believe it's already September. We are doing a 3-part webinar series with X12, with the first 2 occurring this month and next month on the claim transaction and the eligibility and benefits operating rules and standards. So we encourage you to attend those. We are doing a joint session with NACOS looking at interoperability and value-based care. We will have another town hall before the end of the year. And then we will be doing a presentation with one of our board members, Dr. Marilyn Heine from the AMA, who will share the impact of these proposed operating rules to NCVHS, or the NCVHS recommended operating rules from a provider perspective. What does this really mean in the day-to-day life of a physician within a provider's office? So I think that will be a great session. We did something similar at HIMSS earlier this year together. And then we'll be at a number of conferences coming up, HBMA, WEDI, and of course CAQH Connect. I believe the room block registration closes today, so if you are even on the fence about coming, I would go to the website ASAP to get registered to make sure you get that reduced room rate. So please reach out if you have any questions, and thanks so much for joining us.